Yeah, we talked a little bit about ablation already, and essentially the technologies we're talking about involve us putting catheters, thin wires into your heart through the vein in the groin. Typically we put you to sleep when we do it, put some freezing around the vein in the groin, put the catheters up to the heart, get them into the left upper chamber. And in this case, this shows us kind of going around each of these veins that drain blood from the lungs into the left upper chamber and burning the area in order to generate scar that would prevent electrical activity from exiting the veins and causing the arrhythmia. In this case, this is a freezing or a cryo balloon that's placed into the vein to freeze the area around the vein. And, these are some of the newer catheters that allow us to deliver this, cool electric field, for the same purpose. When we do an ablation for atrial fibrillation, we generally speaking don't look for pathways. There are lots of different arrhythmias, lots of different reasons to do it. In some cases, there is a clear abnormal electrical circuit that we map, we look for it, and we zap it. In atrial fibrillation, it's very anatomical. We go into your heart and we want to electrically isolate the veins that drain blood from your lungs into the heart. Some of the time we want to isolate the area between the veins. We call the back wall or the posterior wall of the left upper chamber. Some patients also have this arrhythmia called atrial flutter. And for atrial flutter, we cauterize or ablate the area between the vein from the groin and the valve between the right upper and right lower chambers of the heart. All right. That's it. Generally that covers about like 90% of AF ablation. So it's not a matter of looking for any specific spots. It's not a matter of looking for specific short circuits. We do that for a lot of other arrhythmias. AFib is very anatomical. We want to make sure that these areas are isolated and electrically silent at the end of the procedure. So, if you are having atrial fibrillation and you've had trouble with medications, maybe time to chat with your physician again about the potential of doing this type of ablation procedure.
And very quick, and I know if there's any questions out there about where you can get that done, I mean, you can connect with us at the HeartFit Clinic, and we can connect you right with their center where you can do ablations pretty quickly as well. And so I know you have a way of getting ablations done very quickly. So if you can just quickly talk about that part, because I get very excited about, not waiting. And
right.
That's very important.
In our case, we've been doing these ablations since I finished my training at the Cleveland Clinic, 20 years ago. At our center, we've grown the program to be doing about 1,000 AF ablations a year. It's one of the biggest, if not the biggest in the country. And we've done a number of things to really optimize the flow of patients through the lab and organization of the lab to where now on a typical day we could do 5 or 6 procedures in one room, and we have 2 rooms doing ablation side by side. So we have a lot of capacity to accommodate additional patient volume. And so recently we've actually created a little website called afibclinic.ca. You can scan the QR code or just dial in the clinic. And it has a lot of information, and we have other teaching materials. I have a number of kind of interviews, conversations, teaching presentations on the various topics related to atrial fibrillation. And it also has a referral form for both physicians to refer patients to us, as well as for the patients to self-refer. For the patients who self-refer, we organize an intake appointment with a nurse practitioner who talks to you, does a little more teaching, make sure that this is the right thing for you. And then if it turns out that ablation is really the way to go, then then we do our best to accommodate that patient at our center. And just to give you an idea, I wonder if I have the pictures here. So what that actually looks like. So we have kind of a prep center here where you come in the morning, you haven't had anything to eat since midnight the night before. The nurse starts an IV, we go through all the paperwork, whatever else we need to do. And then you come into the lab. There's a lot of equipment in the lab, looks kind of like Starship Enterprise. But I have this big screen. I stand over here. I have this big screen. You're on the table. We have an anesthetic machine. We have an anesthetist there. We have nurses in that corner, and this is where we do the procedures. And just to add, just if you don't mind, just add one extra thing. Some patients with atrial fibrillation also benefit from getting a left atrial appendage occlusion device. And these devices are sort of like corks that we can put into this left atrial appendage I talked about earlier. So typically, these are used in patients who need to be on a blood thinner based on the CHA2DS2-VASc score and the risk for having a stroke. But for whatever reason, they cannot take a blood thinner. Typically, it's because of bleeding either in the brain or the gut that cannot be controlled, and they just can't be on a blood thinner safely. And we're one of the few centers, if not, we may be the only or one of very few Canadian centers where we can do an ablation and put one of these devices in the same procedure. And where that's important is that most of the risk of the procedure is getting you on the table, putting you under general anesthetic, and getting the catheter in the left atrium. Well, we're already there if we do the ablation. So this is just a nice little extra sort of bit of information I think is important for a lot of our patients. So we haven't talked about success rates yet, right? I wasn't avoiding it per se, but atrial flutter, where we ablate about an inch worth of tissue between the valve and the vein, as I showed earlier, success rate there is about 95% with one procedure. Atrial fibrillation, because it's a much bigger area we have to cover, and because there are people where arrhythmia comes from somewhere else in the heart, we're about 80% successful on average after one procedure. About 20% of the patients may need to have the procedure repeated, and that's typically at least 3 to 6 months out or more. And about 5% may need to have it repeated another time. And while it's an outpatient procedure, you come in, have it done, takes half an hour to an hour, and you go home the same day. There are risks, so there is a risk of bleeding at the groin, putting catheters in. There is a risk of bleeding around the heart. There's always some risk of a heart attack, stroke, risk to life related to the procedure. So it's not entirely a walk in the park, but again, we do a lot of procedures, and we found that generally speaking, it's very safe, particularly if you do it early. So if somebody is younger, lighter, doesn't have heart failure, doesn't have structural heart disease, the risk of having significant complications is extremely
And
low.
I'll go back to kind of our gig. It's all about focusing on those modifiable things that you can take care of, to start off with.
For sure.
You covered earlier there, right? And so, making sure electrolytes and nutrients and all that stuff is balanced properly, and knowing weight is important, hormone imbalances, genetics even come into play with that side of things. So it's important to know those things, I think, to have a better success rate. Thank you very much for your time. I mean, it's such a good conversation. Like I said, I could probably talk another hour and a half with you, because this is all fascinating to me. And, for those of you out there that want to connect more, obviously there's that information there, and look forward to helping you. Obviously, our gig is to help you with your heart health so you can get the success that you want to get out of
so perhaps you never have to see me at all.
Yeah, or maybe not. Yeah, there you go. So anyway, thank you very much for your time today. And
absolutely.
That was fun.
Thanks so much, Diamond. Pleasure chatting with you.
Excellent.
And look forward to working with you.
Absolutely. Thanks so much.